Hello everyone, I am Srajan Agrawal, sub-editor from Elets Media. I welcome you all to another exciting and informative episode of Elets eHealth Innovation Talk with Dr. Sandeep Nayak. Dr. Sandeep Nayak stands as a prominent figure in the field of surgical oncology in India, known for its expertise and innovation in minimally invasive cancer surgery. Currently serving as the founder and chief of surgical oncology at MACS Clinic, Bangalore, he has dedicated his career to advancing the field through cutting-edge techniques including robotics and endoscopic surgery. Dr. Nayak's impact extends beyond national borders as he has become a sought-after specialist for patients from around the world. Supported by a team of highly experienced cancer specialists in Bangalore, Dr. Nayak aims to make a lasting impact on the lives of those battling cancers, providing not just treatment but also hope for a better and healthier future. We welcome you, sir, and it's a great pleasure to have you with us on this Elets Innovation Talk. Uh,
Thank you, Srajan. Thanks for having me.
it's a pleasure, sir. So, sir, to begin with, my first question to you would be, could you just tell us about your journey in becoming a surgical oncologist and your motivation to specialize in minimally invasive cancer surgery?
See, to become a surgical oncologist, it was mainly because to keep that, a wide array of surgical exposures that we get in as an oncosurgeon. Because as a trainee in general surgery, when I was in Calicut Medical College, uh, the complex works which we were doing were always oncological because it was always cancer. So rest of it was not so complex. It was okay to do. So and whenever any complex work was required, it was oncosurgeon who had to come in and rescue many of the situations. So that fascinated me, and I started thinking that it's a good idea to go into the direction of surgical oncology rather than any other field. Because once you finish general surgery, it is always about what next, how to go about. So what are the avenues which are available? So surgical oncology emerged to be one of the major avenues in which I thought there is a lot of opportunity to do good work. That's how I chose it. And then once I completed the training in surgical oncology, I realized that uh, much of it was in the concept of that a big surgery. Cancer surgeries are generally considered big surgeries. So a big surgery, big wound was the concept very often thought of. But then there was already a lot of evidence that laparoscopic and robotic surgery does a lot of difference to the patients. There is an impact. So and evidence was emerging at that time that okay, this is safe, this is effective. And that is when I started thinking that no, I should specialize and see what I can do the best in this particular field, how I can do the best in this particular field. So my focus went from being an surgical oncologist or mere surgical oncologist to becoming a minimal access surgical oncologist or minimally invasive surgical oncologist. So that was a transition when I completed, and then I had to dedicatedly work towards the skill development and how to train myself, because training opportunities also were very less. It was not something like which was commonly done. Everyone was not doing it. So training opportunities were less, concepts were very vague. So we had to, or I had to really work towards it, grow the field, and I had to grow along with the field. So so that is how the things started shaping up, and I started doing more work in surgical, minimal access surgical oncology.
So, sir, my next question to you would be, what inspired you to establish MACS Clinic and focus on minimally invasive cancer surgery?
Okay, so see, when I see I was working in various places in India. So when I had to look at when I had to look at coming back to South India, where I am from Bangalore. I'm from originally
Oh,
from Bangalore. But I wanted to say, let me come back to home. So I actually came back to Bangalore, and went to. I didn't want to be in the metro. To be very frank, I didn't want to be in
Oh,
Bangalore. So I went around looking for smaller cities, tier two cities, and all that, to see whether anywhere I can be accommodated. So, but when I started telling that I want to only do minimal access surgery, minimal access surgical oncology, everybody said no, we don't even have a proper laparoscopy setup to provide you the service. So I had to literally then think, what do I do next? So that's how, when I was looking around, that's when I got this opportunity at Kidwai. At that time, the director was also looking to grow minimal access surgery in the hospital in Kidwai Memorial Institute of Oncology, which is a premier oncology center in India, also in Bangalore
India.
also.
Yeah.
Yeah, it is a government institution. So that's how I got in there, and then that became an opportunity to uh, grow. And when I was coming out of that place, I realized that there was not much of not much happening in Bangalore in the form of minimal access cancer surgery. And that is how I started the clinic. The name is Minimal Access Cancer Surgery, MACS, is Minimal Access
Minimal.
Cancer Surgery Clinic. So that is how I just wanted to promote minimal access cancer surgery, and that is how the entire concept started. So it was very humble beginning, wherein I knew there was nothing much happening in the form of minimal access. So I had to first tell people that okay, this is possible. Even doctors were very skeptical about it. Doctors were not sure, like where we don't know anybody doing minimal access for cancer, and this is some new guy has come to Bangalore and talking about it. So it had to be pushed quite hard when it came to minimal access. Yes, there was some very minimal acceptance, but today the things have changed. Over time, a lot of people, a lot of all the hospitals are having minimal, laparoscopy. There are huge amount of hospitals which have robotic today. So things changed over time, and things have emerged. So I think you know I have also grown along with the system. That's what I can say. So rather than whether I have contributed a little, but I have grown along with it when it grew. Otherwise, I also could have just sat around and not done anything.
Yeah.
I just grew along with it. And the most important part of that growth was forming this clinic, so that there is a platform on which I could promote the entire thing. Otherwise, there was no other way. Nobody was actually interested in
Yeah.
promoting minimal access cancer surgery, lapro robotic. Nobody was interested at that time. I i did approach some big players in the market, big multi what do you call, the corporate hospitals. None of them
Okay.
were keen on this. Nobody was keen.
This clinic is like really truly inspiring for like many others. So, sir, related to this, my next question would be, sir, what are the major challenges did you face in this role, and how did you overcome them for the for the best of your patients to care them at the best? Yeah.
So challenges wise, to you know to begin with, was to the beginning was acceptance of minimal access itself. When I started about 12 13 years back, it was like in Bangalore. So it was like, uh, if I say minimal access, there would be other 10 people who will say open surgery to the patient, same patient. So that was one challenge which was always there. Other challenge which comes up whenever we talk about minimal access is the cost involved. So see, the cost of minimal access surgery is always higher than open surgery, because of the equipments involved, the techniques and technology that has to go in. So what people do see is that upfront cost that they have to spend for the surgery. But actually there is an indirect benefit to it, in the sense that, see, minimal access surgery reduces the recovery time. So in the long run, the recovery time, the complication rates are less. In the true sense, the cost is actually reduced because of that. So, so for people to understand it, it takes time. So these are some of the challenges which we always initially used to face. See, today it's a different thing. People do come to us with the uh, concept that they have to go for robotic or laparoscopic surgery. That, to me at least, they don't come with the intention of going for open surgery. At least that is a
Mm.
fact today. But there was a time when it was not like that. I had to really tell them that, okay, this is what is there, this is there, this is another concept. So each concept had to be explained to them.
Yeah,
So
that's true.
these were the challenges. If that is your question, I don't know. I hope I have answered what you were asking.
Yeah. So, what measures did you take to overcome these challenges for the best possible care for the patients?
See, one is the most important thing that comes up is the education. See, it is not about what I want to do. It's about what is best for the patient who's sitting in front of you. So, uh, see, overcoming these challenges is about giving the right kind of education to the patient
Yeah.
and telling them, because these are the things, when these are the risks, these are the problems, these are the things which you have to keep in mind when you go for this particular surgery. So, one is
Mm.
education. Second is the cost implications. So one of the things which I started doing is, I started giving a variety of options to the patient. Even today, I am associated with a corporate hospital as well as a charitable hospital.
Yeah.
So that if I have a patient for the same kind of work, if I am able to give these to same patient, I can do it at a lower cost here, because there is a different patient who come for corporate. There's a group of patients who will come for a lesser
Lesser.
cost hospital.
Yeah.
So I can give the same care here as well. So that is one of the ways in which I have found a balance to find this problem associated with uh, you know this particular issue.
Yeah.
Like,
Yeah.
how solving this issue predominantly.
G- So, sir, are there any recent innovations or technological advancements in the cancer surgery that you find particularly promising or exciting for this industry, for this cancer, this disease?
See, technology and techniques are always evolving. So there is, the moment we hit a stagnation, that means, there's something totally wrong. So, so see, sometimes the technology comes up front, and then we learn to use it in a different way. And there
Yeah.
are times when the technique comes, and then we have to develop the technology to adopt it. So
Mhm.
both things happen. So if you are, for example, see, robotic surgery, robotic, the technology was developed for heart, actually, heart surgeries originally.
Okay.
But actually, it never, very few cases of heart surgery were done with the robot. Actually, it utterly failed in heart. But what happened was, it got used predominantly for prostate cancer.
Oh, okay.
So it was actually targeting heart, but ended up on prostate. Okay,
So,
so the entire technology got repurposed, and maximum, if you look at many countries, prostate is the place where they are using robo for the maximum. Now, see, nobody thought that robotic surgery will ever be used for head and neck cancers. Okay, so see, today there are few of us in the world. There are about two or three people in this world who are predominantly focused on head and neck cancer surgery using robo.
oh,
Okay, there are three, four of us who are doing across the world. and I'm one of them. There is one person, one in Korea, who's Professor Kaur, who's practicing head and neck surgery. He does it, and there are a few others whom we can count across the world. So we all had to repurpose something which was invented for altogether some other purpose without the help of the robotic companies also. They never want to. They are always they have their own agendas. So we had to really rework the things, redo the things, and invent it, do a very innovative work in the field of oncology. So we had to reinvent. These are newer things which came up: robotic head and neck surgeries, robotic. So now my technique, like rabbit for thyroid surgery, rabbit technique, it's popularly known as rabbit.
Okay.
So it is big, it's taken up by so many people across India. At least it's very popular now. Most of the people are using that technique. So like that, I have invented the robotic neck dissection, which is called Ria Mind. So that
Oh,
technique also has become quite popularly used by many people. So you know, there was a time when for very low rectum cancer, rectum is the last part of the intestine, just before anus. So the standard teaching when we were students was, if from the anus, if you are able to feel the cancer, then we have to remove the anus and put a permanent bag.
okay.
Okay, so then with the laparoscopy, the vision quality improved. It's not just that we are not putting a wound, because we are putting a camera inside. Vision quality in the abdomen improved.
Okay.
If you know how to use, your quality of vision is better with minimal access than with open surgery, because your camera goes inside, you're seeing on a big screen.
Yeah.
So over time, see, the techniques improved, evolved. Today, you see, 90% of the low rectal cancers, the cancers which are very low down in the anus, we are able to do what the technique called intersphincter resection, or ISR, predominantly done robotically, and we are able to save all those sphincters. People avoid a permanent bag. So this is something which is a bigger evolution in the technology and technique. Parallelly, it's a technique which came on a technology which was already there.
Yeah.
Robotic technology was there, but we developed technique using on the technology. So these are all newer innovations. So
Okay, sir.
like that. So these are the new things. Now other new things see, there are two parallel, as you say. Technology has to be developed by technical side. Ideas may be sometimes surgeons. From the
Yeah.
engineering side, they think something, they develop something, and then the surgeons need to use it. So that is how it works. Many things like that we keep inventing. So you need to have an innovative mind to reutilize and repurpose what has been developed by the engineers. So it's a very
Yeah.
collaborative work.
Yeah, so that's true. So, sir, what other technologies beside robotics is like taking a boom in this industry, according to you?
Other thing which is coming up is fluorescence.
Sorry?
Fluorescence technology.
Fluorescence. Okay.
Fluorescence, yeah.
Yeah.
Fluorescence means, like, you have the lamp lighting behind, right? So say, when the surgeon is operating, if a technique or something can be developed to light up a structure which he wants to remove or wants to save,
Okay.
so then he or she knows what to do. See, for
Yeah.
example, if you are removing say some organ, say, I'll just give you, because something which you can understand. So you are removing some, say, a thyroid, but you want to save the nerve to the voice for voice. Now there may be a surgeon who may be finding it difficult to identify that, right?
Yeah.
So, but say, imagine a technology or a fluorescence technique which will, with the light, when in the camera, it can show that this is the nerve, lit up nicely, red or blue or green or whatever it is. So that makes it easier for the surgeon to identify and save it. So
Got
this is coming up in a big way now. So this
it.
is fluorescence in surgery. So fluorescence is something which people are very actively working on, and it is an emerging thing which is already there. It's not like may come or anything like that. It's already there. We use it regularly for many things, but currently only one dye is being used regularly. But there are things which are coming up in the next version. In fact, in next few months only another new technology will get introduced, which will be able to detect many newer things, like newer organs, where like there is some from the tube which joins kidney to the urinary bladder ureter, that
Okay.
identification also is made easy by certain things. So such kind of things are coming up, and this is an emerging thing. It can happen. uh, it is already there, so that is one. Other thing which is coming up in medical field is artificial intelligence.
Yeah.
So AI in surgery is becoming another big thing. So in fact, I see the role of AI in many things as of today. See, for example, identification again, using set identification of structures. There are many companies who are working on face identification, like surgery. Which phase is it? Is
Mm.
in this phase? Can we have we identified this structure? So can we save this? Can we save that? So this kind of a framework in which AI is coming in a big way in surgery, or superimposition of uh, the thing that augmented reality.
Yeah.
So augmented reality things are coming up in a big way, where surgeon can superimpose the CT scan image at the time of surgery and see whether the structure is fitting into that.
Yes.
The surgeon doesn't have to go to the side and check. There will be a superimposed image which will come. He's looking at kidney in the patient. At the same time, kidney is seen with the tumor sitting over there. So you know where to cut. You don't have to think
Yeah.
too much,
Yeah.
right? So all these things are coming up. So but these are all things which will come up in the minimal invasive segment, because vision quality of minimal access, that is laparoscopy and robotic, cannot be matched in open surgery. The vision is completely different. So these are, if you ask me, these are the things which are something which are coming up. It's all about the next few, era is all about improving vision in decision making.
Yes, sir. So these technologies are really like playing a great role in the healthcare and this oncology system. And so, sir, my last question to you would be: could you share a success story where your patient's experience stood out in terms of the impact of your treatment and care?
See, success stories and failure stories will be many in any field.
That's that's
So
true.
I think at the same, when we celebrate success, we should have the grace to accept failures also,
True.
right? So yeah, so I generally don't want to share only uh, us one story, or uh, one side of the entire picture. But if you ask me, like what I really see some of the things which I have started, like for example, when I see uh, the rabbit technique, robotic thyroid surgery technique, rabbit. When I see my patients coming back, most of the rabbit thyroid surgeries we are doing are for young patients, very young, like they are below, most of them are below 40, and many of them are around 20s. I have done a child also, so operate for a child. So what happens is, these are all people who uh, don't want a scar in front of the neck.
Yeah.
So they all come to me for that reason. Though to me, when I see the results of my surgery, I feel that I'm doing it more for quality of the surgery rather than for the scar itself, because I feel of the technology which is available in it, my quality of surgery is much better. But when I see my patients come back with nothing, even I can't recognize that, I have done a thyroid surgery, or sometimes neck lymph node dissection, no scar in the neck, nothing is there. They come with nicely exposing their neck, and come so confidently. That itself is sometimes a success story. I keep telling the patients, I can't. It's an unfortunate thing that I can't identify my thyroid patients, because there's no scar in the neck.
Yeah.
All other surgeons will have the pleasure of identify, because those patients have a scar in front of the neck. My patients don't have, so I can't identify them. So in a way, jokingly, I tell all of them that I can't recognize my patients. Same way, if you ask me the success of this intestinal tract resection, that is low rectal cancers.
Mm.
Very often, I get patients coming from everywhere, from across the world. Sometimes, people come. So the whole, uh, the thing about it is, see, a young patient who has in fact, these are like, patients in their 30s, 40s, and all. You know, for them to live a life with a stoma, a bag, permanent bag where stool is collected, is a big challenge, because they have to live with not only that they have to live with it, there are complications associated with it. Nearly 40% of these patients will have some or the other complications associated with the stoma.
Okay.
So when I see my patients, uh, when we do this technique called ISR, they have to struggle with the motions for 1 year, 1.5 years, but they retain their, normal passage. They don't have to struggle with the bag. They don't have to go on with their life in that with that bag. So that is also a success story for me. Like, this is like, for these patients, it makes a huge impact. They really don't want to go with none of them. Nobody wants to feel different from what they are. So saving and restoring normalcy is something which I really have enjoyed doing.
Okay. So, sir, I just curious to know one thing. Like, what is so common? Like, why this disease is like rapidly increasing in this age group, like below 40? Like, what is the reason behind it?
See, it's not only increasing under the age of 40; it is increasing across population cancer. The reason is, see, there was a time, like if you look at 1900s and all, like I'm talking about the previous century, most of the deaths and diseases were infectious diseases. So they were not non-infectious diseases. But in the last century, when we came towards the end of last century, like 90s and
90. Oh,
yeah, 80s, 90s, 70s, 80s, 90s, we were able to control most of the infectious diseases. Nowadays, you don't hear about cholera, huge typhoid outbreaks with people so many thousands dying.
yeah.
When I was a kid, I used to hear about cholera. I used to hear about huge epidemics of. So we are not having so much death because of infections and all that. Most of the infections we are able to control and manage today. So what has happened is the incidence of infections came down, non-infectious diseases has gone up,
Mhm.
and we are living longer. If you look at 90s, in the 20th century, people were dying at the age of 40s. Average life expectancy was below 40 years.
Okay.
Now it is above. So what happens is we are like, living up to 70, 80. So what happens as you get older is genetic defects, then genetic damages starts accumulating. And because of that accumulation, finally what happens, you get cancer. The chronic diseases increase, like heart diseases, diabetes, hypertension, cancer. All these are diseases of chronicity. So that is what is happening today. So that is why you are seeing the increase in incidence of cancer.
Yeah, got it, sir. Yeah. Thank you so much, sir, for being with us throughout the such in informative and interactive session, and it was very good hearing you today and having you on with us.
Thank you. Thanks for having me.
Thank you, sir. Thank you so much.